Dr. Sarah Ahmed. I'm a practicing internal medicine physician in the US, and I have passion teaching. So I decided to start a series of lectures and lessons to help USMLE students. These are USMLE steps 1, 2, and 3, with emphasis on helping the step 3 candidates in particular. To start this process, I decided to start with this topic of epidemiology, biostatistics, and quality improvement. These subjects have this reputation of being dry and they feel alien. Although this couldn't be furthest from the truth, as epidemiology is the backbone of progress in healthcare in the past few decades. It's the foundation of any new discoveries that we are integrating on a daily basis in our clinical practice. We need to understand that epidemiology is the way to transform population-level research and translate it into individualized patient care. It's the biggest first step into transforming population-based research and studies and integrating it into clinical practice. I want you to get 2 learning objectives from this lesson. The way I designed teaching videos or lessons is based on the philosophy of microlearning. I decided to start with epidemiology, and you have a series of micro lessons that will explain the important concepts and terms and whatever you need to understand as it pertains to the USMLE exams. So this is the first series, and we are starting with epidemiology. I'm going to link it to evidence-based medicine. First, we need to understand that epidemiological research serves as the foundation for evidence-based medicine. The real-world challenges of applying evidence-based medicine in clinical settings. It's not a straightforward process, and it's challenged in so many ways, given that these research results, despite the fact that they are very impressive in terms of their significance, a lot of obstacles are in the way in terms of applying that high quality results to clinical practice. So, what is epidemiology? Epidemiology provides scientific tools to study disease patterns, risk factors, and treatment outcomes in populations. It generates evidence through systematic surveillance and well-designed studies, forming the backbone of modern medical knowledge. We can credit epidemiology for advances that we made in healthcare. Evidence-based medicine builds on the foundation set by epidemiology. In medicine, evidence-based medicine combines 3 essential elements: the best available evidence from epidemiological studies, and this will take a lot of our focus as we go along in this series. Number 2 is clinical expertise. People need to remember there is a big human element in healthcare, okay? Healthcare providers themselves are humans, and our patients are humans. So we are in the business of dealing with people. And that makes everything different from any other industry. Evidence-based practices are implemented in so many other industries: aviation, automotive industries, space industries, whatever. Any of the engineering practices, they do have evidence-based practices and they do implement it on a daily basis. And that's how they get to progress within their field. But They are dealing with machines. Whatever they discover, whatever they research, and they find out that it improves the performance of their units or machines or creates any advancement in their field, they can implement it directly. Given the competitive nature of these fields, companies would like to be the first in everything. They can implement it very quickly. This can improve the efficiency of what they do and the performance of their machinery. This is not easy in medical practice. We deal with three things: high quality research, clinical expertise of the healthcare providers, and the third is the patient preferences. Their individual values, their circumstances, or the circumstances that surround them, and all this needs to be put into consideration prior to making any clinical decision. So it's not about implementing this new discovery in medicine and implementing it on everybody and everywhere without these considerations. This will never work, and it will never be as successful as other industries. The essential points, this epidemiology actually, first of all, it starts from population level studies. So we are studying populations to generate information that can be used to help individual patients, meaning improve the way we care for patients. So epidemiology deals with populations. We need to generate robust evidence through well-designed observational studies and clinical trials. And we'll talk about that in the upcoming lessons. We need to be rigorous and critical about what we do and how we generate evidence. We employ systematic approaches to minimize biases and ensure validity. The evidence-based medicine is actually the bridge between these results obtained through epidemiological studies and what we do on a daily basis within our clinical practice. We need to translate what studies concluded into clinical application. Evidence-based medicine uses study design, risk measurement, and bias assessment to evaluate evidence quality. We need to make sure it's robust, relevant, high-quality evidence, reproducible, and relevant to our patients. Then translate these population-level findings into clinical decision-making for individual patients. That's the bridge of evidence-based medicine. But healthcare is unique. Why? Because we deal with people, it's very difficult. We have high-quality evidence, no doubt, but we have issues related to whom we apply it on, and issues related to who is weighing and making decisions using this evidence. These are the healthcare providers. We need to balance the benefits from new evidence and our patients' values, preferences. In the middle is the healthcare provider's judgment and decision-making. This is important in everyday encounters with patients, our clinical judgment. The other thing that we need to remember about humans is that they are unique. Each one of us is different, not just the average of the population tested in the study that came up with all these results. It's not that. We cannot consider people as an average of this population. Patients have different allergy profiles, different responses, different side effects profiles, idiosyncrasies. They have other psychological elements that goes into the way we make decisions. They might say, no, I don't want it. Or they might say, I cannot afford it. All these factors play a role. And you are the one who is there looking at that patient and weighing and balancing things. Okay? So you look at the patient, their background, the contextual factors like practice setting, resources, insurance coverage, cultural norms, they all affect our decision making. Okay? And the other element that you need to remember about study results and designs is that rare conditions and diseases which actually affect real people, there is not much evidence or not much research and focus on them. So you don't have a lot of evidential support in dealing with these conditions, which is another challenge. The epidemiology did a study, large RCTs demonstrate statins reduce cardiovascular risk in adults with strong statistical significance. It's robust, clear, no doubt about it. Then we come to the individual practice. The patient may decline using statins. This happens so frequently, especially with statins. Why? Because of side effects, because of the cost, because of concerns or personal beliefs. Yes, you have the evidence, but they have their own beliefs and they are set on their decisions. Then in this case, clinicians weighs research evidence with patient preferences and the circumstances surrounding their presentation and their life for personalized care. Despite robust evidence that statins reduce the risk of cardiovascular events, still we can face situations where we don't provide it or prescribe it to our patients. Think of a scenario where research shows a strong evidence for a treatment at the population level, some studies that brought big results, yet individual circumstances make its application complicated. Think of something like that from your hospital rounds or clinical work. Have you faced this? Look at the factors that led to this inability to apply that good evidence to your patient. Medical factors like comorbidities, contraindications, drug interactions, allergies, disease severity, prognosis. Social factors, support systems, caregivers, cultural beliefs, practices, health literacy levels. Other possible factors, healthcare access resources, insurance coverage, geographic economic barriers, and possibilities are endless when applying evidence to clinical practice. This is why we call it the art of medicine. It's not pure science. There is a big part of it as art. Managing the situation in front of you. Every patient is unique. You have expertise, knowledge, and ability to make decisions. You need to weigh these things and make decisions shared with your patient. Nowadays, we don't dictate to patients, we involve them. They participate in decision making. Epidemiology and evidence-based medicine are inseparable. Epidemiology provides the evidence-based medicine, ensures this evidence is thoughtfully applied to patients. The art of medicine lies in integrating science, patient individuality, real-world context. This is Paris. Please join me next about confounding and bias. Thank you.